In this lecture, we'll cover disorders of the peripheral nervous system. We'll spend a good chunk of time covering mechanical neuropathies, which are caused by pressure placed onto nerves at compressible sites. And these would be bony structures that nerves pass through. The most common example is the carpal tunnel, which causes entrapment at the wrist. But there are other places, and we'll cover those from head to toe. Then we'll cover post-polio syndrome, which is the loss of lower motor neurons many years following a polio infection. Charcot-Marie Tooth disease has two variants, and both of them cause peripheral neurodegeneration. Diabetic neuropathy occurs downstream of diabetes. This can occur in both type 1 and type 2 diabetes. And there are several patterns of diabetic neuropathy possible. We'll end the talk with a mixed bag of toxins that can affect our peripheral nervous system. So for our mechanical entrapment disorders, this is just compression of a nerve that then leads to first demyelination, and if left untreated, eventually loss of the neuron itself. So let's get a couple of fancy words into our heads here. Three of them. So we've got neuropraxia. This is just demyelination. That's it. Axonotmesis. This is damage to the axon, but not the surrounding connective tissue. If we damage the whole nerve, that's neurotmesis. So nice little cartoon over here. Here's a happy neuron and a few neighbors. Its axon's running in this big old bundle of neurons here, the nerve itself. And we've got nice green myelin sheaths. When we lose the myelin, but everything else is fine, we call it neuropraxia. If we lose the axon, we call it axonotmesis, so long as the rest of the nerve is intact. But when we have some kind of crush or laceration injury that damages the connective tissue, we now have neurotmesis. And these are ordered in terms of the least to most severe. With neuropraxia, so long as we can take care of whatever's causing the compression, we should expect full recovery, because we can make new myelin. Sure, we lost 3 Schwann cells in this cartoon. No big deal. Much like me, they are easily replaceable. With axonotmesis, hey, so we've lost the axon. No big deal. We're in the peripheral nervous system, so we can regrow this. However, that's going to take some time, so we could get full recovery. It's going to take months to years. If we lose the neuron because it failed to regrow, let's say we had some kind of, we'll make it red, red is bad. We have some kind of thing compressing us here, and we didn't relieve that pressure, the neuron can never regrow, doesn't form synapses, use it or lose it. So if we lose this neuron, it, like you, is special and irreplaceable. So our recovery will be partial rather than full. Now that failure to regrow is a whole lot more likely in the case of neurotmesis. That's because we've lost our path. So when this axon up top is trying to regrow, it's just going to follow along the original path. It's going to follow along the connective tissue that's already there until it finally forms its nice synapse. And everyone's happy. Down here on the bottom, oh no, we've lost our road. Now when we surgically reconnect our nerve, what if it gets rotated a bit? Maybe this axon goes down the wrong path and ends up forming a synapse in a different location. We're kind of okay with that because at least we've formed a synapse. If, on the other hand, we don't go down that path and we get lost and we form like a whirl or something and we never form a synapse, well, that's no good. This just creates a little painful structure that exists until that neuron happens to die off. Now we can tell the difference between these with a little bit of nerve recording. So if we have neuropraxia, we're never losing the axon. We'll only see axon death with axonotmesis and neurotmesis. So here what they're doing is causing a little bit of an injury at this squiggle site here. S1 is distal to the injury. S2 proximal. So if we stimulated S1, even though we're damaging here, this part of the axon is still functional. So if we stim here, the action potential is going to go in both directions. That doesn't matter. It'll certainly go in the forward direction, and we get some kind of electrical event. That's what we're recording down here. We see it at day 1, we see it at day 10. The fact that we're seeing it 9 days later means that we still have an axon. So do we have an axon? Yes. And yes. We have an axon at day 1 in these cases down here. But how about day 10? Let me get my crap out of the way. Ooh, no response. Why is that? Well, because it's an axonotmesis or neurotmesis, we get degeneration of the axon. So between day 1 and day 10, this axon slowly degenerates. We get anterograde axonal degeneration. And so we see no response down here at day 10. So this tells us we have death of the axon, and therefore it cannot be neuropraxia. When we're dealing with neuropathies in general, we see the longer axons affected earlier than the shorter axons. And this should make sense. Longer axons are more expensive, so it's easier to kill them. So when you see longer, I want you to translate that to more expensive. And that's just simply because they have longer axons, and therefore they have to move more ions every time they fire an action potential. That means they're more susceptible to oxidative stress. The other reason longer axons will be affected more often is that they're longer. They cover more area, and therefore they're more likely to be compressed. So typically what we find is what we call the stocking and glove pattern of impairment, because it takes the longest axons to get down to the hands and the feet, the stockings, the gloves. Now, these neuropathies could involve a single nerve, mononeuropathy, or multiple nerves, polyneuropathies. They might also affect the nerve root. In that case, we're dealing with radiculopathies. And it could be one, a radiculopathy, or a polyradiculopathy. It depends on how many roots. In this case, we can kind of see the effects of a radiculopathy. It radiates out from the spine down along the distribution of that nerve root. So here's something like a C5, C6, somewhere in that ballpark. Radiculopathy. I'm going to go back. Notice in the neuropathy, we can indeed skip. So we're not affecting from the spine and out. No, we're just affecting the stockings or the gloves, the feet or the hands. With a radiculopathy, no skipping. We go from where the root begins all along its distribution. So with mechanical neuropathies, what's going on is that some pressure is placed onto the nerve at some inelastic structure. Great example is the carpal tunnel. Now, what's causing the pressure? Well, could be some kind of an injury that changes the structure of that inelastic place. So it could be it moves the bones around or something along those lines. We could have infection or inflammation or a tumor growing. So we might have a thing that's decreasing the amount of space available and thus increasing pressure. Or you might just be, unfortunately, born with it. We're all snowflakes, and so all of us have slightly different body structures. Some folks are going to have a carpal tunnel that's really prone to causing nerve compression. Whatever the cause is, once we have an increase in pressure, what's going on is early on demyelination. That is neuropraxia. So when we get to pushing on the nerve, the first thing we get rid of is the cushion. That is myelin. So the first thing to go away is the myelin, and this should make sense. We got our axon running here. How can you tell that's an axon? There you go. And then surrounding that axon, we've got the myelin. So just think about what's the first thing to get encountered whenever we start to place pressure. What am I going to hit first? Leave it in the comments. No, I'm kidding. We hit, boom, the myelin. So this is going to be the first thing to get pressure placed on it, not the axon. So the myelin is the cushion when we get to pushing. What does that cause? So when we lose the myelin, obviously we get conduction block. All right, how do we fix it? Well, we could remyelinate, but if we haven't gotten rid of the pressure, that's not an option. So instead, we stick in those additional ion channels and jack up the cost for each action potential. That, of course, leads to the good old oxidative stress and apoptosis, just like it did in last lecture and the one before that and the one before that and probably the one before that too. That pressure can eventually cause axonotmesis. That is the loss of the axon. More specifically, loss of the neuron. The way that it can do that is, of course, with the oxidative stress leading to apoptosis. But the ischemia itself can then lead to apoptosis. So as the pressure increases, not only are we pushing on myelin, but we can also push on blood vessels. If we decrease blood flow, obviously those neurons aren't going to be able to pay the bill, and so that depolarization will then lead to excitotoxicity. So we got a couple of ways of getting to axonotmesis. It could be because of the neurotmesis, the demyelination that leads to oxidative stress. It could be that the pressure continues to increase and then we get ischemia. Either way, we've lost a neuron and now we're not going to have full recovery. So with entrapment disorders, early treatment is obviously better. Now that injury tends to get worse over time with these entrapment disorders. Right? We're going to see progressive symptoms, and that's because of this unfortunate positive feedback loop. We get our pressure, that injures us, as discussed in the last slide. That leads to an inflammatory response that, you guessed it, increases pressure. We have got ourselves an unfortunate positive feedback loop. Not only that, we're forming scar tissue, which leads to fibrosis. So nerves can no longer glide around in joints. Instead, they get trapped in place, and when we bend our wrist or something like that, that pulls on the nerve, stimulating nerve fibers and creating pain. Now, speaking of pain, there's a few ways of getting it. First of all, inflammation directly stimulates nociceptive afferents. So when we're inflamed, we're in pain. Pressure also stimulates nociceptive afferents. Think about this. We're dealing with C fibers. These are the smallest ones. C fibers are very small, thus they have a very high resistance. So whenever we press on them and generate a current, the amount of potential change that we get is a whole lot greater for a small fiber. So we can mechanically stimulate nociceptive afferents, or we can chemically stimulate them with inflammation. And then, hey, let's say we injure the axon, we demyelinate it, that can stimulate pain fibers through a process called ephaptic transmission. So what's going on there is the demyelinated axon spits out a bunch of potassium. All right, so let's get a couple of axons here. This one's myelinated, but it lost it at one site. So we'll get a little bit of demyelinated segment here. And then we've got a nice skinny C fiber running through it. So this axon will tell me about, I don't know, some non-painful tactile sensation. And this one over here tells me about pain. Okay, so when I stimulate this tactile axon over here, it's going to conduct action potentials, and one of the things that it'll do is spit out a whole bunch of potassium. Now, normally it won't spit out a bunch of potassium in this site, but now it's got a huge stretch where it spits out potassium. Don't forget, when we increase potassium outside, that leads to depolarization of the nearby axons. So now, even though the action potential was running over here in my non-painful tactile fiber, at the demyelinated site, it jumps over here through the release of potassium and stimulates the pain-sensing fibers through good old haptic transmission. So now let's walk through our mechanical neuropathies from pretty much top to bottom. I think that's the order I've gone in. So for trigeminal neuralgia, here we're compressing the trigeminal nerve, and most commonly it's because of some sagging blood vessel. All right, tends to occur a little more commonly in females than males. Some cases are inherited here. And here we can actually see this superior cerebellar artery dipping down onto the trigeminal nerve. So we can surgically fix this. So we lift that superior cerebellar artery up, taking the pressure off, and we relieve trigeminal neuralgia symptoms. Now, it tends to come on later in life. You can see, fortunately, a nice little bell-shaped curve here, most commonly in this 50 to kind of 70s range there. Risk factors would be anything that affects blood vessel integrity. So hypertension, atherosclerosis, right? Those are going to be certainly risk factors. Viral infection, obviously that can lead to inflammation and can entrap nerve fibers there as well. Here we can see the effect of hypertension, increasing the incidence of trigeminal neuralgia compared to the non-hypertension group. Bell's palsy is another cranial nerve entrapment, but this time the facial nerve. And this tends to occur as it's running through the temporal bone. So this kind of, here's the facial nerve, and it enters the temporal bone and runs through this winding path here before finally exiting. So all the places where it's a little translucent, it's running through bone. That means it's highly compressible. And a common cause of compression is viral infection. For example, the herpes virus infection. There are other possible causes, absolutely, but infection is a very common form of, a very common cause of Bell's palsy. When we compress the facial nerve, this leads to facial weakness. As opposed to in trigeminal neuralgia, when we compress the trigeminal nerve, that leads mostly to pain in the face because of a haptic transmission. With Bell's palsy, because this is a motor nerve, we get weakness of the face. Bell's palsy would be the lesion B shown here, that is damage to the facial nerve after it emerges here from the pons. And this pattern of weakness looks very different from what we see in stroke. So if we have damage to the upper motor neurons because of a stroke in the cortex or any of the cortical bulbar fibers, you'll notice the upper face is spared. We're really only seeing weakness in the lower part of the face. That's because of this right here. We have dual innervation or bilateral innervation of the lower motor neurons that control the upper face. So this lower motor neuron here controlling the eyebrows and the forehead there, that one gets input not only from the right side, but also the left side. This is probably why it's hard for most of us to raise a single eyebrow and leave the other one alone. That's one of the many things that makes the rock special. But most of us can control the two sides of our face differently, at least our lower face. You know, you can give that horrible half smile. That's kind of what we're seeing here. That social smile that people put on when they see you walk down the hallway. With Bell's palsy, we see both the upper and lower face affected because we're damaging the lower motor neurons. There is no dual innervation from the other side here. No. The left facial nerve controls the left side of the face. The right facial nerve can't pick up the slack over here. So we see the loss of those forehead wrinkles. When we have upper motor neuron damage, only the lower part is affected. Thoracic outlet syndrome is moving now away from cranial nerves. Now we're in the brachial plexus. And here we have either compression of the nerves or the vasculature, which then creates the symptoms, somewhere in the brachial plexus. Now, this is kind of a controversial diagnosis. It's more commonly diagnosed by surgeons compared to neurologists, and that's because the treatment for this is surgery. And the diagnosis is far more common when there's private insurance involved or workman's comp because they pay more for the surgery. If you have Medicaid, somehow you almost never get thoracic outlet syndrome. It's crazy how that works. Somehow the disease knows what insurance you have. So anyway, the risk factor of this would be repetitive upper limb elevation and use. So if you're reaching up, right, potentially compressing structures within your brachial plexus, that's the risk factor. Obviously, this is going to lead to weakness and sensory changes in the arm. Saturday night palsy or radial nerve palsy is caused by compression of the radial nerve, usually at the upper medial arm or over here, the axilla. And the classic cause of this is getting drunk on a Saturday night, and it has to be a Saturday night. Otherwise, it's not Saturday night palsy. Then falling asleep with your arms slumped over a chair. There are other things that can cause it. You can get drunk on a Friday night. I guess we'd probably still call it Saturday night palsy. Or you could have something else that's causing the pressure besides a drunken stupor. Anything that's putting pressure on the radial nerve for a long period of time can indeed cause radial nerve palsy. The outlook's pretty good here. Sleep in your bed instead of the chair. Wait several weeks. You'll be fine. Tardy ulnar palsy is caused by compression moving on down the arm at the elbow, the cubital tunnel where the ulnar nerve is running. There it is right there. There's our ulnar nerve, also called the funny bone. And you can see it's got bone on a couple of sides here. So obviously this is a compressible site. Repeated injury to the elbow or just bad luck. If you chose to be born with a shallow ulnar groove, you're more likely to get tardy ulnar palsy. And in this case, we'll have decreased function of the ulnar nerve. So there'll be weakness and sensory loss along its distribution in the 4th and 5th digits there. Carpal tunnel syndrome is the most common upper limb neuropathy, in case that wasn't obvious by the bold text there. And it's a major cause of lost work days. So this is fairly common compared to those others. I haven't hammered on the incidence, but go back, have a look. You'll see those numbers are much higher than what we've covered in the others. What we're doing here is compressing the median nerve in the carpal tunnel. There's our median nerve, here's our carpal tunnel, and look at that, we're surrounded by bone, or I guess a ligament, whatever the hell those things are. I don't know, it's not the brain, so don't ask me. But it's definitely a compressible site. And that's why we have carpal tunnel syndrome so common. The use here, the big risk factor here is repetitive use. And hey, here's the deal with hands. They're handy. We use them a lot. So that's why carpal tunnel syndrome is fairly common. Repetitive use of the hands is something that we all do. right? And if your rests are commonly in, I think it's extension, but I'm really stupid, so don't ask me, and you're typing with bad posture, well, that's something we all do nowadays, and so not surprising, this is a fairly common diagnosis. We see a 2 to 2.5, somewhere in that range, to 1 female to male ratio. Could be because they have a smaller carpal tunnel. Could be that, classically, women took on secretarial roles and tended to type more than men. That is probably not the case nowadays. I type pretty much all day, every day. So computers are a lot more common. That explanation is probably falling away as our society advances. But whatever the reason, we can most certainly see a whole lot more females getting carpal tunnel than males. Doesn't mean you won't get it if you're a male. Hell, I probably have it going on right now. Now, there's a lot of things that can cause carpal tunnel syndrome. Certainly, repetitive use is a big one. That's kind of what this whole bullet point is about. But there's a lot of other things, and I'll let you read that in your own time. Moving on down, we've got sciatica. Here we're dealing with either compression of the roots. This is, I think, a misuse of the term sciatica. I think there it has to be the sciatic nerve, but it could be the roots. People still call it sciatica. Either way, here we're gonna compress the nerve or the roots that make up the nerve, and we're gonna get pain in our back if it's a radiculopathy, or just pain in the leg if it's the nerve. Most common cause here is that disc herniation, as you can see there, but there are other things that can do it, right? Anything that's pressing on the sciatic nerve, whether it's a tumor growing or a blood clot or something like that. Same old idea. We're going to demyelinate and get all of our symptoms there. You can see here, fairly common diagnosis. And big risk factors here would be, if you're bending over a lot or you're bent over in some awkward position, that increases your risk there. All right, so we got our mechanical neuropathies out of the way. Let's move on down the list here. So post-polio syndrome comes on after we get a polio infection and work through that whole thing. We think we're out of the woods, and then decades later, boom, we're hit with another round of worsening weakness. Now, the good news is if you never had polio, you won't get post-polio syndrome. So it's a very rare disorder, and you have to have prior polio infection. Now, in developed countries where we take our vaccines, so long as we're not drinking some kind of weird Kool-Aid about vaccines being bad for you, the polio vaccine has eradicated post-polio syndrome here in the U.S. But hey, back in the day, back in the bad old days before we had the polio vaccine, there we go, that's what I was looking for, we'd get a lot of polio infections, and here you can see some kiddos lined up wearing their leg braces and whatnot. How times have changed. So the polio virus infects motor neurons and kills them off. So in the acute polio infection, we'd kill off motor neurons. So this one was unlucky. Boom, it's gone. Hey, we've left some muscle fibers without neurons innervating them. Well, the neighbors pick up the slack. They remodel, and now we recover our motor function. How nice. But the neighbors had to pick up the slack, right? They had to grow more axons. That makes them more expensive. What happens? The same stuff that we've seen time and time again. So those surviving motor neurons that innervated those deinnervated muscle fibers now have more metabolic stress. And this leads to cell death the way it has in every other lecture. Free radicals permeabilize the mitochondria, and that leads to apoptosis. Boom. Charcot-Marie Tooth disease comes in a couple of flavors. One is a demyelinating disease, and the other impairs axonal transport. Either way, they're a peripheral neuropathy, so let's cover them. You can see here, certainly on the rare side of things. The risk certainly depends on where you live. You know, if you're over in Norway, your risk is a whole lot higher than over here in the UK. Certainly a family history increases your risk. There's several genes that can cause Charcot-Marie Tooth disease. Most of them we see are autosomal dominant, but there is an X-linked dominant version of Charcot-Marie Tooth as well. And anything that damages nerve function can worsen Charcot-Marie Tooth disease. All right, so in Charcot-Marie Tooth 1, CMT1, here this is demyelination. That's what it is. So there's a bunch of mutations that can occur in proteins that we find in myelin. And this causes the myelin to not form properly. So rather than getting a nice single Schwann cell myelinating this fiber here, right? Nice orderly myelination, we get this kind of bundling up. Here's another Schwann cell and another one and another one and another one. So the myelin doesn't properly form and you get this onion ball enlargement that's palpable. Over here, we're not seeing any of those enlargements. Here's an axon, myelinated, single myelination, not getting multiple myelination there. And so when the myelin doesn't form properly, over time what this leads to is demyelination. And then demyelination in the peroneal nerve is going to give us the symptoms in the lower limb that will be covered in the next video. CMT2 is caused by not a problem with the myelin, but a problem with axonal transport. So a few proteins could be involved here. These mutations seem to all slow down anterograde transport. So this is the same horrible thing that we've seen before. Here we've got a few mutants, and you can see compared to the wild type, the number of mitochondria moving down the axon decreases significantly. If you really like chymographs, here it is. So the red picture is just showing you the mitochondria. That's just a snapshot. So there's where they're tracking. There's the axon there. And then on the bottom, see these squiggles, how they go, this one moves to the right, this one's up and down. This one kind of shifts to the left there. This one jumps to the right. That one moves to the right. You'll notice they're not all vertical, like down here. Yeah, we got one that moves over, but pretty much everything is vertical. This is in the mutant. So when we have those Charcot-Marie Tooth mutations, if it's not affecting the myelin, it's slowing axonal transport. So now we don't get organelles like mitochondria into the axon. We can't pay the bill. We don't survive. Or we don't put proteins into the synapse. Use it or lose it. Diabetic neuropathy is a bit of a mixed bag here. Lots of different things can happen. And this occurs downstream of diabetes. So if you don't have diabetes, you won't get diabetic neuropathy. Now, if you have diabetes, whether it's type 1 or type 2, diabetic neuropathy is an option. We see it in both adults and adolescents with type 1 and type 2 diabetes. Overall, pretty similar risks for type 1 and type 2 diabetes in terms of developing diabetic neuropathy, so neither one of them are absolved from this risk. Like everything, age makes this worse, so the older you get, the more likely you are to have diabetic neuropathy. The longer you've had diabetes, the more likely you are to have diabetic neuropathy. If we see any signs of just kind of poor health in general, like elevated hemoglobin A1C, this will indicate that you are not controlling your blood sugar very well. If you're not controlling your blood pressure very well, or your fats very well, all of those increase the risk of diabetic neuropathy. Now, there's a few types of diabetic neuropathy. So first of all, there can be a very transient form that's just caused by the hyperglycemia associated with diabetes. So if we're not cleaning up the sugar in our blood, moving it into cells, it stays in the blood, and that seems to potentially hyperactivate calcium channels or modify the activity of calcium channels to make them more excitable. So you'll tend to see hyperexcitability of pain-sensing nerve fibers. But this is reversible. Bring the blood sugar back down, symptoms go away. As far as the neuropathies go, These can be small fiber, that is affecting more the pain and temperature sensing fibers. This is a big problem. If we, for example, can't feel pain in our feet and we develop sores, we're not going to be able to sense that and properly take care of them. So foot care is a bit of an issue. Large fiber neuropathy affects the tactile fibers as well as the motor fibers. So in this case, we'll have pain sense and temperature sense fine, but we won't feel normal sensation and we'll have weakness. This can make us more likely to fall because we can't feel the ground and we're a bit weak, so it's hard to catch ourselves. As far as the diabetic neuropathy goes, it could simply be, that loss of the small fibers, acute sensory. It could be polyneuropathy, where we're hitting a mix of sensory, motor, and autonomic fibers. And this is more common among those types. So what's the problem in diabetes? It's all about insulin dysfunction. And to understand why that's a problem, we need to understand insulin's functions. One of the important things that it does is affect the vasculature. Insulin triggers vasodilation. So if we can't vasodilate as well, then blood flow will be decreased, increasing our risk of ischemia. So that could be an issue here. And here we can see why, dyslipidemia would be a problem. So in obese humans here, when they deliver a dose of insulin to them, the amount of relaxation is much lower than non-obese controls. So this is just showing us that insulin is a vasodilator. If we can't vasodilate, we run the risk of not having enough blood supply. Now, classically, insulin is there to help us take up glucose, and that is absolutely what it does. So here's a cell. There's the surface of it. Most of the green glucose transporters are on the inside. Hit it with some insulin, and look. Now, largely what we're seeing is the membrane filled up with glucose transporters. Here we can kind of see like a faint outline of the membrane, just kind of dotted a bit with glucose transporters. Insulin causes translocation of those glucose transporters to the surface. So we haven't lost our glucose transporters, we've just put them on the surface, and that's where we want them. That's where we pick up all the yummy glucose. So if we have insulin dysfunction, either we're not making the insulin or the insulin receptor doesn't really work very well, then we're not going to increase the amount of glucose transporters and we're not going to be able to pay the bill as well. You'll notice both of these effects are basically the same. If we don't vasodilate, we don't make as much ATP. If we don't pick up as much glucose, we don't make as much ATP. We can't pay the bill, we depolarize, we get excitotoxicity. Nothing new, just a different way of getting it. But that's not all. If you order now, insulin will also serve as a neurotrophic factor. And this is the reason why we struggled for so long to grow neurons in a dish. We as in humans, not you. You've never struggled to do that. But if you try to grow a neuron in an insulin-free medium, they won't do it. Neurons need insulin to survive. It's only when you have some insulin around, and in fact a whopping dose, that you can convince neurons to grow in a dish. What insulin does there is probably exactly what you'd expect it to do. It increases the expression of anti-apoptotic BCL2 proteins. And here they are, right here. BCL2, BCLXL, both anti-apoptotic BCL2 proteins. And here's the good old, I believe, Western blot analysis of that. So if insulin doesn't function, then we don't pick up glucose, we don't vasodilate, we don't pay the bill. We also don't express anti-apoptotic BCL2 proteins, and we don't escape default. That is, our neurons die. And they die from head to toe. Now, there's a few patterns of injury that we see in diabetes. There's the kind of classic distal symmetric polyneuropathy, the stocking and glove distribution. We can also see radiculopathies, where we kind of radiate along here. We might see mononeuropathies, maybe just this one, or this one, or this one. Obviously not all three at the same time, that wouldn't be mono anymore. We also see autonomic neuropathy, where largely what's affected is autonomic function. You've heard it's what's on the inside that counts. That's what we're affecting here. So here we're going to see changes in heart function and digestion, urination, all that jazz. And guess what? You can have a mix of autonomic neuropathy along with the distal symmetric polyneuropathy. Diabetes will screw you over in many ways. Oh, and I mentioned head to toe. Speaking of the head, diabetic retinopathy is a thing. So not only do we see death of our neurons out there in peripheral nerves, heck, we see them in the retina too. Here's a normal retina. How beautiful. Over here, we've got a diabetic retina. Now, obviously, this looks a little bit worse. We can see signs of hemorrhages all over the place. That's probably those vascular effects. Hey, we also see these things called cotton wool spots. And that just shows us we have ischemic injury to the retina. So not only are we going to affect the limbs and the viscera, we're going to also affect the retina as well. I don't think anyone would disagree with me when I say diabetes sucks. Last little bit here, we've got a few toxins that can affect our nervous system, and some of them are actually useful to us. Lead, not so much. I guess it was helpful to make paint way back in the day. Luckily, we're not doing that anymore. Now, with lead poisoning, what we get is wrist drop. That's the most common symptom there. So mostly what we're affecting are the upper limbs. So here, radial nerve is clearly not doing its thing. Okay, so I love these old movies. There's a link there. You can check it out in your own time. It's in the slides. What we're seeing here, obviously, upper limbs are affected. If this goes on long enough, we'll see limb wasting, and that's because of the loss of nerves. Now, acutely, what lead poisoning does is inhibit calcium channels, voltage-gated calcium channels. That is the calcium channels that open up when a neuron fires an action potential. So, if we inhibit our voltage-gated calcium channels, no neurotransmitter release occurs. Let's have a look at the data. So here what they're doing is controlling the membrane potential. So we're resting and then we're depolarizing. And when we depolarize, like what happens in the action potential, notice we get this inward current. In other words, calcium comes in. As we increase the dose of lead, notice the amount of calcium coming in decreases. So the amount of neurotransmitter going out also decreases. So you'll get weakness, sensory changes. You get the point. Lead also creates free radicals, and this can lead to the lingering symptoms where you don't come back to baseline after you treat with EDTA. EDTA is just a little chemical that chelates divalent cations like lead. So if you have lead poisoning, get a bunch of EDTA and essentially cover the lead so that it can't, stick to your calcium channels and do all that stuff. Organophosphates are kind of useful toxins. We use them in pesticides to kill insects and stuff like that. They're also used as chemical warfare agents, although I think we should make love, not war. So I'll use them as pesticides if I ever use them at all. Okay, so what do organophosphates do? Well, these are cholinesterase inhibitors. And cholinesterase inhibitors are kind of nice, unless they work too well, and that's the problem with organophosphates. These are really potent cholinesterase inhibitors. So they can lead to something called cholinergic crisis, and that's where we have hyperactivation of parasympathetic fibers because we inhibited cholinesterase, so we didn't break down acetylcholine. So look at all these red dots appearing. Oh no, we've got too much acetylcholine. And that might be at a neuromuscular junction like right here. It could also be at a parasympathetic synapse. So, cholinergic crisis, parasympathetic effects. At the neuromuscular junction, the one that we're most concerned with here would be those for the respiratory muscles. So that respiratory paralysis is because of effects on the neuromuscular junction. How do we treat it? Well, as far as the cholinergic crisis goes, we can give atropine. Bring our heart rate back up, make us not drool as much, because that will antagonize muscarinic acetylcholine receptors. This doesn't help us so much at the neuromuscular junction. There, what we have to do are use cholinesterase activators. Now, you might be wondering, why is it that too much acetylcholine leads to paralysis? Well, we overactivate the acetylcholine receptor, either putting the muscle in depolarization block, or we desensitize the acetylcholine receptors so they stop depolarizing the muscle. There's a few ways. We want that nice baby bear range of acetylcholine. Not too much, because we get paralyzed. Not too little, we're immobile. Boy, I hope I spelled that right. We want a nice middle-of-the-road dose of acetylcholine. That's where we can move. Hold on. I think I added an extra joint on my stick man. Oh boy, well, you know what? It's not worth it. You get the point. All right, last bit here. Botulinum toxins, or clostridial toxins, are a group of toxins that destroy the proteins needed to release neurotransmitters. They're called the snare proteins. More on those next semester. So a number of bacteria can make clostridial toxins. And these are all anaerobic bacteria. That's why if you're going to can food, you want to make sure it's clean. You don't have any anaerobic bacteria hanging out in there just waiting for you to open that can of beans and get a case of botulism. So when we are exposed to this bacterium or the clostridial toxins, what they do is bind to surface proteins and get taken inside. There, they separate so that the light chain comes off and cuts up the snare proteins. Without the snare proteins here, we don't fuse vesicles and release neurotransmitters. So botulism then leads to the inability to spit out neurotransmitters. So we get paralysis as a result. The treatment for this, antibodies. So we have antitoxins that bind to botulinum toxins and prevent them from interacting with their receptor. And next thing you know, you've cleared up your problem there. Now, botulinum toxins are certainly useful in the laboratory to understand how the brain works, and also in the clinic. It can make people beautiful by getting rid of their facial wrinkles. So we just cause a little bit of paralysis up there in the forehead, and there you go, you got rid of your wrinkles. This is a much safer way of getting rid of them than Bell's palsy. And I think that about does it. Let's make sure. Yep, that about does it. So make sure you can answer these questions and all the rest of them that I give you. If you have anything that's unclear, fill out that questions box so I know what to talk about in class. I'll see you there.